Hello and welcome to the Neurocritical Care Society Hot Topics podcast. I'm your host, Dr. Nick Morris from the University of Maryland Shock Trauma Hospital. And today I am really excited about our topic. We're talking about one of the newest, latest, and greatest trials in neurocritical care and critical care medicine in general. And that is the ANNEXA-I trial, which was published recently in the New England Journal of Medicine. And we are really, really excited today. We have one of the study authors, Dr. Ashkan Shoamanesh, and we have Andrew Webb from clinical pharmacist extraordinaire from Mass General Hospital. And thanks so much to both of you for joining me to talk about this trial. Everyone's talking about this, and now we could do so on the podcast. If you wouldn't mind, maybe Ashkan, you could start just by introducing yourself so people know a little bit about who you are and your background.
Yeah, sure. So my name is Ashkan Shoamanesh. I'm a stroke neurologist at McMaster University, where I'm an associate professor and hold the Martin Owen Boris Chair in Stroke Research and Care. I'm also a senior scientist as well as the director of the Hemorrhagic Stroke Research Program at the affiliated Population Health Research Institute that led the ANNEXA-I study under the leadership of a colleague of mine who's unfortunately passed, but was really the main driver of the entire ANNEXA program, and that's Stuart Connell.
And Andy.
Yeah, awesome. Thank you again for the invitation to the podcast. My name is Andrew Webb. I am the clinical pharmacy specialist in neurocritical care here at Mass General, where I'm kind of involved in the both clinical and research care of patients with ICH. I'm very excited to talk about this.
Well, thanks again for both of you to take time out of your day to talk about ANNEXA-I. And Ashkan, maybe we can start with you. Why is it so important to reverse the effect of factor 10A inhibitors in patients with ICH, and how does andexanet alpha actually accomplish that goal?
Yeah, I think it's a great question to start us off. So, of course, with the increased uptake of factor 10A inhibitors in the management of patients with cardiovascular disease, and namely atrial fibrillation, we're seeing more and more patients presenting to hospital with major bleeds on factor 10A inhibitors, and 10% of those bleeds are intracranial. Um, although when we compare baseline ICH severity in terms of volume or neurological severity on the NIH stroke scale, the bleeds that occur in factor 10A inhibitors tend to be slightly less disabling and less large in terms of baseline volumes when compared to vitamin K antagonists or warfarin. These patients still are at a high risk of expansion. The rate of expansion is 40%. So irrespective of whether you're on a vitamin K antagonist or a factor 10A inhibitor or direct oral anticoagulant. And the mortality at 30 days is the same in both groups, about 25%. And this actually suggests there's even a better window of opportunity to perhaps improve outcomes in patients with factor 10A inhibitor ICH, because if you were to freeze them in that in that baseline presentation of smaller bleeds with less severity, you can actually have even a greater impact than, for instance, a VKA-related bleed when they're already presenting with larger volumes and a worse severity in terms of their stroke scale. And how kind of andexanet alpha works in this context is that it's basically tailor-made, and in simplistic terms, is a decoy molecule that competitively binds factor 10A inhibitors with high affinity, essentially competing for native factor 10A, thus allowing the native or endogenous factor 10A to be freed from the factor 10A inhibitor and to engage in the hemostatic cascade accordingly.
Great. And of course, this wasn't the first study looking at the effects of andexanet alpha. So before ANNEXA-I, we had ANNEXA-4. And can you take us just briefly through the results of ANNEXA-4 and kind of what research question, what gap did it leave that ANNEXA-I hoped to fill?
Yeah, for sure. So the early phase ANNEXA studies in healthy volunteers first showed that andexanet alpha 1 can rapidly reduce anti-factor 10A activity in healthy volunteers who were treated with rivaroxaban and apixaban in those particular studies. And then that led to the ANNEXA-4 study, which was essentially looking at patients and it was 352 patients who presented with acute major bleeding, and they were within 18 hours of their last dose. The predominant indication for anticoagulation in that study was atrial fibrillation, which was present in 80% of the population. And as opposed to, for instance, the earlier idarucizumab study, the majority of major bleeds in ANNEXA-4 were intracranial hemorrhages and relevant to ANNEXA-I and neurocritical care. So 64% of baseline major bleeding in ANNEXA-4 was intracranial hemorrhages. And what was interesting is that the expansion rate in ANNEXA-4 was much less and almost half of what you would have expected in a similar population that hadn't received andexanet alpha. So as we discussed earlier, the expected rate of expansion in patients with DOAC-related ICH is about 40%. And in ANNEXA-4, the expansion rate was 20%. However, and of course that was promising as a signal, but because there was no comparator arm, we could never say for certain whether that was a treatment effect or maybe there was some selection bias and that led to lower risk patients getting included in the study. Similarly, there was a higher rate of thrombotic events at about 10%. But again, because there was no comparator arm, we couldn't say whether there was a treatment effect or whether this was just the natural history of a prothrombotic population who's on anticoagulant for a reason, and when by reversing their anticoagulation, you're manifesting their underlying prothrombotic risk in the context of a bleed where their inflammatory markers and coagulation factors are going to be upregulated. On the basis of ANNEXA-4, several jurisdictions such as the FDA, EMA from Europe, and Health Canada did provide conditional approval for andexanet alpha, but that conditional approval was contingent on the successful completion of a subsequent randomized trial in a massive bleeding situation or a rather life-threatening bleeding situation, acute life-threatening bleeding situation. And ICH was chosen specifically because of all the acute major bleeds. It is the condition where we could most accurately measure bleeding and hematoma growth, whereas, for instance, in other settings like as GI bleeding, we're really only using surrogates of bleeding, such as drops in hemoglobin, which are less reliable measures of amount of bleeding and achieving hemostasis.
Great. Andy, of course, people have been using other agents to try to reverse the effects of factor Xa inhibitors, and primarily that seems to be PCC. So can you kind of summarize for the listeners, what do we know about the role of PCC in factor Xa related ICH? And particularly, what do we know about it before the publication of ANNEXA-I?
Yeah, definitely. So I think it's important context that, andexanet alpha was FDA approved or approved in the various countries that it's approved in now several years after the initial factor Xa inhibitors were brought to market. So, rivaroxaban and apixaban came to market in the early 2010s. And so there was a good couple of years where there really was not an available targeted antidote or reversal agent for bleeding associated with those agents. And so in kind of the void of available reversal agents, the reversal agent that's oftentimes most familiar to many clinicians for vitamin K antagonist, 4-factor PCC, somewhat tried to fill that gap. And so I think the role leading up to ANNEXA-4 and then past ANNEXA-4 up to ANNEXA-I was essentially 4-factor PCC was somewhat of a indirect procoagulant agent, which tried to essentially promote a more prothrombotic state in a patient who is actively anticoagulated. And so really the data that supported that and really still supports that is largely retrospective, that essentially tried to estimate the rate of hematoma expansion like we've been talking about in patients taking factor Xa inhibitors who present with ICH. And so really up until ANNEXA-I, the quality of the data was largely retrospective, which essentially showed that this non-specific concentrated factor product likely produced some degree of hemostasis. And there is some in vitro studies that show there's at least some cessation of bleeding in patients who receive a DOAC and then are reversed, so to speak, with Kcentra. But the quality of the evidence is not prospective, it's not randomized, and so it's always going to be limited by those retrospective kind of factors. And so I think the other thing that is important to say out loud, maybe say the quiet part out loud, so to speak, is that when ANNEXA was approved, Kcentra was also substantially more cost effective insofar as the initial acquisition price for Andexa was quite high relative to Kcentra. And so I think a lot of centers that may not have had the resources to keep the large enough volume of Andexa on kind of in stock would use Kcentra as a relatively, insensitive or non-specific agent that seemed to promote some sort of a, reversal state. Maybe it wasn't quite as targeted as Indexa, recognizing that the quality of the data that was available wasn't quite as high as Annexa-4, which to date was the only prospective granted single-arm trial with actually reversing the factor Xa inhibitors.
Great. Well, now that we've directly addressed the elephant in the room, maybe we can just take that a little bit further. And there have been some changes to the pricing, right, over time. So I think we have to keep that in mind because undoubtedly, at a lot of institutions, price was sort of biasing all of us to probably favor PCC as well as our own familiarity with the product over andexanet alpha. But the price difference, as I understand it, is not so great anymore. Is that correct?
Yeah, so that's correct. So you're exactly right. When andexanet alpha was first approved, I think the price tag was quite shocking to many people. And so obviously the acquisition cost is going to vary from center to center, but an individual course when it was first approved would run anywhere from $40,000 to $60,000 for, in a single bolus followed by an infusion. And so I think in response to the recognition that that may be a bit over what the value was thought to be when it was first approved, the price has come down quite a bit. And so while it is still generally more expensive than a course of Kcentra now, it is far less expensive. And so I think courses will oftentimes run closer to the $10,000 to $15,000 range. And that's clearly going to vary from center to center as well, which is a little bit more comparable to what, a 50 unit per kilo dose of Kcentra is going to run at for many patients.
Wonderful. I think that sets the scene nicely for us to talk about ANNEXA-I. So Ashkan, if you can, maybe can you take us through sort of the major methods of ANNEXA-I and, starting with who did we include in this study?
Yeah, sure thing. ANNEXA-I was a phase 4 multi-center prospective randomized and open label blinded endpoint trial in patients who were 18 years of age or older who presented with an acute ICH within 6 hours of symptom onset and had taken their last factor Xa inhibitor dose within 15 hours of randomization. Some other key exclusion criteria that are worth noting is that patients who had a symptomatic thrombotic event within the prior 2 weeks were excluded, as were those with very large hematoma volumes of greater than 60 cc's, and those that had NIH stroke scales that were above 35 or low GCS below 7. So really those with the most severe bleeds were excluded from this study. And in this study, patients were randomized 1-to-1 to receive standard dosing of andexanet alpha or usual care. Because particularly when we had first started the trial, there was even less consensus in the community regarding what would constitute standard of care in patients who had factor Xa inhibitor ICH or associated ICH. Due to the paucity of high-level evidence that Andy just mentioned supporting the use of PCC in this context, there was actually some sites that would never use PCC, and hence, if they were randomized to usual care, some opted to treat with nothing. But ultimately, 86% of our usual care arm did receive PCC, and that rate improved over time as more and more guidelines started to endorse it on the basis of the observational data that was coming forth. And the primary efficacy endpoint for the study was effective hemostasis, and it was defined as meeting all 3 of the following criteria. So all 3 had to have met. The first is 35% or less hematomal volume expansion at 12 hours. The second was an NIH stroke scale score increase of less than 7 at 12 hours as a measure of acute neurological deterioration. And then lastly, the absence of any rescue therapy or procedures between 3 and 12 hours after randomization.
Andy, were you surprised at all by any of the inclusion or exclusion criteria or comparators or selection of outcomes in the study?
Yeah, so I think the inclusion criteria of the study is largely what I would have expected for a trial of this type. I think it's important to kind of point out some of the differences in these sorts of, prospectively intentionally designed trials and the observational data that's available insofar as the population that's enrolled somewhat selectively chosen to try to enrich the population that's most likely to see benefit with anticoagulation reversal. So I think it's important to point that out, when we think about Kcentra or any other four-factor PCC product as a potential agent to reverse factor Xa activity. Looking at the observational data, they tend to look at the real-world population that shows up to the hospital, which isn't necessarily exactly the same population that would be enrolled in ANNEXA-I. And I don't think that's necessarily a bad thing, but it's just important to recognize that, the selection or the exclusion of patients with particularly low GCS or particularly large ICH in the context of trying to detect an effect size of a medication is a good thing, where you can enrich the population with the patients who are most likely to see the benefit. But it is important to recognize that it doesn't necessarily reflect all of the patients that we see in clinical practice. We certainly still reverse the anticoagulation of patients who, based on their initial presentation, may have markers like a low GCS or a large ICH volume that would suggest they may have a poor outcome. And so I think the inclusion and exclusion criteria made sense based on trying to see what the effect of andexanet alpha versus standard of care was. But it's just really important to recognize it doesn't necessarily apply to everyone. I think the selection of the outcome was a little interesting, at least from my first read. I think when ANNEXA-I was ongoing and there was the clinicaltrials.gov kind of blurb of what was going on, certainly hemostatic efficacy is an important outcome, but I think myself and some others were a little bit surprised with how, I don't want to say liberal, the degree of neurologic decline was deemed acceptable in terms of a 6-point increase in the NHSS is fairly significant. But I think it also just speaks to trying to find an outcome that you can see a difference. And so I think it's nice to know that both radiographic prevention of radiographic worsening is achieved with either reversal agent as well as prevention of neurologic decline. But I do think the one outcome that I was most excited to see, that was a little bit sad not to see as the primary outcome, was whether or not these patients did better at 3 to 6 months after presentation based on the reversal agent. And I think, when you think about why this trial was designed in terms of the phase 4 trial, trying to kind of justify the initial approval, it's understandable why that decision was made. But I think that's the one outcome from a primary outcome perspective that I was most hoping to see that unfortunately was not the primary outcome of this trial.
And maybe I could just comment, because I actually agree with Andy that really when we do stroke trials, we want to see clinical outcomes and measured at appropriate timings, and for them trials to be powered for those. There is a bit of a historical context on how this outcome arose, and in part it was because that this trial was designed specifically with the FDA to change the conditional approval to a full approval. And actually the office and center through which this went through during the design process was actually not a neuroscience or stroke one, but really it was through the Center for Biologics Evaluation and Research, and then the Office of Tissue and Advanced Therapies. And so it was predominantly the approach of a hematologist, and really what they were just trying to show was that the drug is doing what it's intended to do, stop bleeding. And it delivered what the FDA asked it to do. It essentially showed that andexanet does improve achieving hemostasis better than current standard of care. Another thing that's worth noting is that, for instance, if to have an adequately powered trial, or let's say mortality, in this context, to show a 20% risk reduction in mortality from expected 25% to 20, it would have taken about 3,000 patients. To show a 10% relative risk reduction, it would have taken about 12,000 patients. And this is not just acute ICH patients. These are acute ICH patients on factor Xa inhibitors.
Mm-hmm.
Average recruitment rate was 1 patient per center per year. So delivering such a trial would have taken over 10 years, and no industry sponsor is going to be invested or interested in doing that, particularly when the FDA is asking them to deliver something different.
Yeah, those are some very pragmatic considerations. Can you take us through the plan then for the interim analysis and why the trial actually didn't run to its pre-specified conclusion but was stopped early?
Yeah, for sure. So indeed, there was an pre-specified interim analysis for once 50% of patients were enrolled and had the primary efficacy endpoint adjudicated. There was two reasons for this. The main one actually was actually due for a adaptive sample size re-estimation through the Meta and Pocock method, where essentially if we had a conditional power of less than 30% or greater than 90%, so either it was very unlikely we were going to succeed, or it was extremely likely we were going to succeed with our current sample size of 900 individuals, we would continue as is. And if the conditional power was in this promising zone, but not definitive zone of 30 to 90% conditional power, we would then inflate the sample size to 1,200. However, to our surprise, there was also a built-in efficacy stopping rule at interim analysis. And this was really through a group sequential design using Pocock boundaries, where you essentially divide the p-value by how many looks you take. And this was only going to be 2 looks. And we also employed an alpha spending function by Lan and Mitz to have a bit more flexibility. But the p-value to call overwhelming efficacy at the interim look was less than 0.031 for the primary outcome, and that was met. So the study stopped at about 452 individuals, and that was the primary efficacy population. From the time that the decision, from the time that that 450 was achieved, and the DSMB went through the data and then made a decision, an additional 80 individuals were enrolled. So ultimately, there was about 530 participants in the total study population, and that was our primary safety population. I'll
Got
also
it.
mention, I didn't earlier, in that some secondary outcomes, but of course this didn't weigh into the interim analysis, were the percent change from baseline to nadir and anti-factor Xa activity during the first 2 hours post-randomization, and then some pre-specified safety endpoints were thrombotic events at 30 days, as well as 30-day mortality.
Right. And Ashkan, after you did that pre-specified analysis and looked at the two patient groups, were there any significant differences between the groups that you think are worth noting?
So generally, the two groups were well balanced and the randomization worked as a total study population. Whether or not you want to weigh too much into some of the numerical trends. So differences where there was more than, let's say, a 5% difference between one group of another was that there was a bit of overrepresentation of atrial fibrillation as well as diabetes in the andexanet group. Whether or not that had any role in the excess thrombotic events seen in that group versus usual care, I think is speculative, and I wouldn't put too much emphasis on it. But there were some numerical differences. But for the most part, the trial was well balanced. There was what you would expect, about mean ages late 70s. Older patients have ICH on anticoagulants, and the predominant indication for anticoagulation was atrial fibrillation in about 85% of the population.
Great. Andy, for you, any surprises in the characteristics of the enrolled patients?
Yeah, I agree. I think that the enrolled patients were about what I would expect for the inclusion and exclusion criterion, largely matches the same population that we see here at MGH. I think the one thing that kind of jumped out at me is because of one of the amendments to the protocol, there's a slight higher percent of patients in the andexanet alpha arm who had a non-intracerebral hemorrhage, meaning they had a slightly higher percentage with subarachnoid and subdural hematoma patients, pointing out that, the probably likely because of identifying that those are quite distinct patient groups and the difficulty in measuring the hematoma volume. There were, at least from before the first amendment, a slightly higher percent of patients who received andexanet alpha with that different bleeding type, which I think is just important to point out.
Yeah. And it's an important point, because although initially eligibility allowed any intracranial hemorrhage subtype, once essentially a stroke neurologist started looking at the protocol and started making some amendments, the two things we decided to amend for eligibility is, one, reduce time from symptom onset to presentation of 6 hours, given the importance of time for being able to mitigate hematoma expansion. The paradigm of time as brain, as we know, is equally important in ICH as it is in ischemic stroke. And then secondly, it was the type of intracranial hemorrhage, in that it became quite apparent that our confidence in how reliably we were measuring hematoma volume growth between baseline and 12 hours was not that strong in subdurals and subarachnoids, and because of redistribution and lobulation and so forth. And hence we confined the analysis to intraparenchymal bleeds and intraventricular bleeds, or the eligibility moving forward rather to intraparenchymal intraventricular bleeds, where we have much more experience and comfort in reliably measuring growth.
Yeah, I think that makes total sense to those of us in neurocritical care. Um, I think we've actually gone through the major results of the trial, which did show a significant effect for andexanet alpha in hemostatic efficacy as measured by that composite outcome. Ashkan, maybe you mentioned some of the secondary outcomes, though. What are some of the major secondary outcomes that we should be aware of?
Sure. Yeah, so for the primary efficacy endpoint, it was for every 100 patients treated, 13.4 were more likely to achieve effective hemostasis at 12 hours, so a number needed to treat of less than 10 for that composite. And that was driven primarily by a reduction in hematoma expansion at the 35% threshold. However, there was also numerical trends in favor of andexanet for the acute neurological deterioration of less than 7. So about for every 100 patients treated, 5 were less likely to deteriorate more than 7 points on the NIHSS. And also for every 100 patients, 4 were less likely to need rescue therapy in the andexanet arm. But again, the confidence intervals for those two crossed the null, it's only slightly, however. And then we had a exploratory outcome of MRS of 3 or less at 30 days as a measure of death and disability. And of course, the 3 or less would be a good outcome. And what we found there was a neutral finding. But I think this is a very important point to take when interpreting this data, is that you certainly can criticize the trial's methods for not having adequate power for the MRS. You certainly can criticize the trial methods for not measuring MRS at the appropriate time. For instance, for ICH, we actually now know we need to really get up to 6 months before we could see the distinction of acute interventions manifesting themselves. Historically, we tried 90 days, but actually from ischemic stroke literature and generalized it to ICH, that was a mistake. We really need to go to 180 days or 6 months. So those are methodological criticisms that I think are valid. But to look at this data and say that andexanet alpha did not improve functional outcomes or has no effect on functional outcomes, rather, as a blanket statement is an incorrect interpretation, because we just don't have the power or ability to comment on the MRS in either direction, really. So there's trial methodology criticisms, but you can't say that it had no effect on MRS because we just weren't designed to show that. And now, one way we try to get around that is use a more stringent exploratory threshold of a absolute ICH volume growth of 12.5 cc's. And this threshold has been consistently shown to have the highest positive predictive value for poor outcome after ICH at 90 days. So it has about an 80% positive predictive value, adjusted positive predictive value for having MRS 4 to 6 at 90 days. And here, in the sample of 452 individuals at interim analysis, there was a numerical trend that for every 100 patients treated, 6 were less likely to grow beyond this threshold. And this is not in the primary paper, I don't believe. It may be in a supplement somewhere, but I don't think so. Is that when you looked at this in the total study population of 530 individuals, it was a statistically significant reduction for this threshold at 7 for every 100 patients treated. We're less likely to expand beyond this more stringent clinical threshold. And the reasons we saw these big differences in hemostatic efficacy is just that the drug is tailor-made to reverse the factor Xa inhibitor, right? So when we looked at anti-factor Xa activity at 2 hours, it was reduced by 95% in the andexanet alpha arm versus 27% in the usual care arm. It is worth noting that a 27% reduction in usual care is essentially what you would expect with saline. It's really just the metabolism of the drug. And there's been several studies that have looked at, in healthy volunteers, the effects of PCC versus saline for reversing anti-factor Xa activity. It's biologically impossible for it to reverse that value. A simplistic way of thinking about it is that there's no factor Xa in PCC, and that so first, you're only giving factor 10. and the factor 10 needs to be converted to factor 10A before it can compete at all with the factor 10A inhibitor, but also that the concentration of factor 10 in PCC is just insufficient to competitively inhibit the factor 10A inhibitor. And you would need to give exceedingly large doses of it beyond current kind of doses used in clinical practice to overcome that effect directly. There is some bypassing activity that Andy mentioned, where you do get normalization of the endogenous thrombin potential or their capacity to build thrombin and by extension clot. However, it's delayed, right? As opposed to immediate reversal with andexanet alpha. At best, I've seen maybe an hour and a half, and many studies actually say up to 6 hours, but there's a bit of nuance there regarding the degree of anti-factor 10A activity on board at baseline and the dose of PCC used. But even in the best case scenarios, it takes about an hour. And then we're going to talk about some of the future studies later, but one of them is looking at ETP, and we have measured ETP at 1 hour and at 12 hours. Unfortunately, we don't have more in between that 1 and 12-hour window, but essentially, without giving too much away, our data supports that ETP is not normalized at 1 hour in the PCC group, whereas it is in the andexanet group. So that's one. And then in terms of something else that I think is worth mentioning is that one, when we looked at different treatment interactions according to subgroups that have biological plausibility to have an interaction for the outcome, we really found no statistically significant differences across the board. And that included whether someone received edoxaban or rivaroxaban or apixaban. The reason I mention edoxaban is that edoxaban has greater biological distribution and that you basically reabsorb more from the tissues, and you have a lesser effect on anti-factor 10A activity, about 75% as opposed to 95%. But ultimately, that didn't make a difference for achieving hemostatic efficacy relative to usual care. And then the second piece is that when you looked at those patients who were destined to receive PCC as part of usual care versus those that were destined to receive nothing as part of usual care, there was really the effect of andexanet alpha was no different whatsoever. If anything, numerically went against PCC, but that's just chance numerical findings. And although that's not a perfect comparison of the effect of PCC versus usual care, it's actually a very imperfect one because there's non-random reasons why someone may have been selected to receive PCC as part of usual care versus not. And when you combine that with the lack of effect of PCC in terms of a biological mechanism or subpar effects from biological mechanism on what we're trying to reverse here, and the fact that when it does occur in the normalization of ETP, it's in a delayed fashion, and the majority of ICH expansion is front-loaded, I am a big skeptic of whether PCC has any major role in an acute confined space ICH in patients who are presenting with elevated anti-factor 10A levels. It's worth noting that the lower bound of the confidence interval for anti-factor 10A activity at baseline in our study was 75, right? And typically, it's when you get above 75 that PCC has this very delayed response in terms of normalization of ETP. And as far as the ANNEXA-I criteria go, the vast majority of patients would have had levels of 75 or greater.
Great. Well, that all sounds very positive. Andy, you wanted to chime in. Go ahead.
Yeah, I guess just one thing I'm curious to get your thoughts on. With ANNEXA-4, I think that it's clear from both ANNEXA-4 and ANNEXA-I that andexanet alpha does what it's supposed to do insofar as it can bind factor 10 inhibitors and neutralize that anti-10A activity. But I'm curious if in ANNEXA-I, you guys are also trying to see whether or not neutralization of that anti-factor 10A activity is in fact correlated with hemostatic efficacy. In ANNEXA-4, there was suggestion that was the case for the AUC for that model is like 0.64 for ICH patients, but I'm wondering if that same analysis is being conducted for ANNEXA-I.
So we've looked at this, and in univariate analysis, there is a correlation between degree of anti-factor 10A activity at baseline and expansion. We haven't done the analysis of the delta and correlation with hematoma growth. That is something we will do. A multivariable analysis in our hematoma expansion model, the effect size of the relationship between anti-factor 10A activity at baseline and hematoma growth was no longer statistically significant. The p-value goes to like 0.05. But the effect size doesn't change. And we think part of that may be due to collinearity with a baseline ICH volume being a stronger predictor of growth. And of course, the greater anti-factor Xa activity you have on board, the greater your baseline ICH volume. So, but there is at least a link there between the anti-factor Xa activity and the propensity for someone to grow. We have to look at the delta correlation, which we haven't done yet. However, interestingly, there may be two ways by which andexanet alpha can mitigate growth in this context. The first, of course, is the direct target of anti-factor Xa activity. The second is inhibition of TFPI, and that we now know that andexanet alpha can bind a tissue factor pathway inhibitor. And by inhibiting TFPI, you're basically upregulating the tissue factor 7 complex pathway. That could be driving some of the benefits in hemostatic efficacy, but also driving some of the excess thrombotic events that we haven't touched on yet. But that's also worth considering, so that the correlation with hematoma growth may not be as strong as you would expect if it was only acting on hematoma growth through anti-factor Xa activity, and that added benefit slash kind of two-edged sword of the TFPI inhibition may be playing a role as well.
Yeah, that's kind of my interpretation too, is that it's very clear that andexanet alpha rapidly decreases anti-10A while PCC does not. But I think the conclusion that delta is like the most important outcome is still a little bit unclear. Probably have some role, and that those off-target effects, both from andexanet alpha and from 4-factor PCC, seem to play a significant role. And to your point, it's the expediency of that onset, which is probably what matters.
Yeah, and again, the proof is in the pudding, right? Like if you look at the rate of expansion in those that receive PCC, forget the 13% that receive nothing, it was 50%, right? That's about that, even higher than that 40% that you would expect in this population when you receive nothing, right? In andexanet alpha arm, it was 67%, so it was 33%, right? So a fairly large reduction in hematoma growth. And whatever's causing it, you can't deny that fact, right? You can't deny the fact that it's mitigating hematoma growth much more effectively. And that so far, we haven't seen any compelling evidence that PCC does that in an ICH setting.
Great, Ashkan, maybe we can move on then to some of the safety analyses. And you mentioned the increased thrombotic risk from ANNEXA-4, and that kind of bore out in the ANNEXA-I study. Can you go into a little more detail there?
So similar to what we saw in ANNEXA-4, the rate of thrombotic events in the andexanet alpha arm of ANNEXA-I was 10%. So really replicated that event rate. And it was double basically what was happening in the usual care arm. So for every 100 patients treated, 5 were more likely to have a thrombotic event. So that's a number needed to harm, about 20 relative to that number needed to treat to prevent hematoma expansion of less than 10. When we look at ICH patients, so we exclude those with subdurals and subarachnoids, the number needed to harm increases to about 26, and the number needed to treat goes down to about 7. So at least there seems to be when you play that numbers game, a potential for net benefit there. Now, what is concerning, of course, is that the majority of these thrombotic events were not TVTs, for instance, that have lesser clinical relevance in terms of death and disability, but ischemic stroke, right? So if that numbers game were to hold true, we would need to show that at least the clinical, or at least assume that the clinical consequence of a hematoma expansion is similar to the clinical consequence of a thrombotic event, particularly when most of these are ischemic strokes. So for instance, it doesn't make sense to balance the number needed to treat for stubbing your toe versus the number needed to harm of having an ICH, right? You want to make sure that that numbers game has some equal weighting in terms of clinical significance. And so we did that. We presented that at the ESOC, where we looked at the clinical consequences in an adjusted regression model of hematoma expansion on death at 30 days and MRS 4 to 6 at 30 days, and similarly for thrombotic events. And what we found was that for death at 30 days, it was essentially the same, about a 3-fold excess risk of death with a thrombotic event or a hematoma expansion event. And then for the outcome of MRS of 4 to 6 at night is actually there was a stronger correlation with hematoma expansion. There was about a twofold excess risk of MRS 4 to 6 in those that expanded, adjusted correlation. Whereas in the effect size for thrombotic events was about 1.3, and that did not reach statistical significance. But mind you, there were less thrombotic events with 37 events, so the power for that analysis was less. But I think a conservative interpretation of that analysis is that to the best of our capacity through such a model, which is prone to residual confounding, however, the clinical significance of a hematoma expansion event is similar to that of a thrombotic event, so that that trade-off of number needed to treat versus number needed to harm is a reasonable one. And when we do that trade-off, the number needed to treat is half the number needed to harm. There's a couple of exceptions that I'll get into. And then we kind of already touched on why we think we may have excess thrombotic events. I think the first is that we know now from work from Santosh Murthy and others that patients with ICH are at high risk of thrombotic events, right? Having an ICH upregulates inflammatory cytokines, coagulation factors. So you are at higher risk of thrombotic events immediately post-ICH, but also long-term. And we're in one arm of the study, we're effectively reversing the anticoagulant very quickly. On the other arm, we believe we're not. Part of that, I think, is manifestation of their intrinsic thrombotic potential. There's also this TFPI relationship. What's interesting with that is that the TFPI remains elevated for about 4 days, whereas the excess thrombotic events were really only in the first 2 days. So there is you would perhaps expect the excess thrombotic events to have lasted the full 4 days of the inhibition of TFPI, if that was the main driver, and we didn't see that. But certainly we know that inhibiting TFPI does make you more prothrombotic. So it's likely a combination of both. But there is that discrepancy between the timing of thrombotic events and how long the duration of TFPI inhibition lasts.
Great. Ashkan, one question I had about the stroke assessment was how were these strokes assessed? We all know that stroke does not always equal stroke depending on what we're talking about. Were these routine MRIs where we see these little areas of remote restricted diffusion that we think are maybe related to impaired autoregulation, blood pressure?
It's an excellent question.
Or what?
And it's a bit of a sore spot for me, and I've had some research interest on this remote DWI lesions for some time, and we looked at that in the ATTAC-2 trial and so forth. So that was a big concern of mine, right? And particularly because this is an open label study. And because of the ANNEXA-4 results showing that 10% thrombotic event rate, and the physicians knew who was receiving andexanet, if they had a mild change in their NIH, or if they had a mild change in their level of consciousness, they may have been much more trigger happy to obtain an MRI in one arm versus the other, actually causing a bias towards detecting more ischemic strokes, quote unquote, in the andexanet arm. So that's one concern. And unfortunately, although all these strokes were adjudicated by a committee of stroke neurologists, we did not collect the baseline MRIs. And we're still in talks about perhaps doing so kind of after the fact now, but it gets complicated since all the RABs have expired and so forth. But having read through all the radiology reports, or at least their summaries that were highlighted by the adjudication committee, I would say 30 to 40% of these events may be these remote DWI lesions, and that they were described as punctate DWI lesions, and the degree of clinical deterioration wasn't substantial. It was a change in level of consciousness or a mild change in NIH. So although the majority were bona fide strokes from their descriptions, there is that 30 to 40% that did not seem that at least could have been questionable to be these epiphenomena that we see post-ICH that could occur in a quarter of patients. So it's so one thing eventually we want to do, is not a priority at this time, but is to at least see if there is an imbalance in these more less clinically profound events categorized as stroke, and whether we can gain any insights in that regard. relative to the more larger kind of bona fide strokes.
Okay, that would be very, very interesting. I think we'd all
Yeah.
be excited to see that.
Yeah.
Andy, what are your overall reactions to this study?
Yeah, so I mean, it's kind of a big question as to what the overall takeaway is. I think us clinical pharmacists and physicians and neurologists are kind of faced with now we have this data that clearly andexanet alpha does what it's supposed to do. There's improvements in hematoma expansion and that clinical kind of composite outcome. That's pretty clear. But the next question is kind of what to do with the data. And so I think my challenge when I first read the study is I think the real main question that I think all of us have, and as we've talked about, is just a methodologic flaw, is whether or not the prevention of hematoma expansion with the more targeted reversal agent does in fact have the clinical benefit in terms of functional outcomes that we all expect that it does. And so I think kind of going back to that secondary analysis that was presented at ESOC, which showed that clearly hematoma expansion is associated with worse functional outcomes at 3 months. What really still hasn't been shown is whether or not that's actually a modifiable risk factor. So I think the presumption is that it should be. But treatment allocation wasn't included in that model, and we have other interventions that also reduce hematoma expansion, like factor 7A and tranexamic acid in the FAST and TITCH trials, and it hasn't borne out to that functional benefit. And clearly, those are two very different studies in different populations, so you can't extrapolate that exactly. But I think my overall takeaway is, pharmacists reading this literature and applying it to my patients is that, andexanet alpha works. It does what it's supposed to do. It reverses factor 10A inhibitors and clearly has radiologic and potentially clinical benefits over PCC based on how it was defined in the study. But I think for a lot of people, and myself included, there is still that missing piece as to whether those functional outcomes are improved. And I think that the hope is that there is, but I think that the tragedy is that this debate will likely continue until that question is answered. And so I think that my hope is that hematoma expansion is a modifiable risk factor, and a targeted reversal agent does make our patients better. But that missing link is really important. And one of the things that I think is particularly interesting is like very well taken that the number needed to treat balanced with the number needed to harm does seems to favor andexanet alpha. But it's interesting. I think as we're reading literature and thinking about interventions, I think we're quite sensitive to small risks that might not necessarily be logically, outweighed by the benefit. And so I think a lot of readers, and myself included, were quite alarmed by that increased risk of an ischemic stroke with, the potential that maybe those strokes aren't quite as clinically, big of a clinical consequence as we are kind of worried about. And even though that numeric increase is not as large as the numeric benefit, I think in terms of human psychology, that risk really does weigh. And so I think what we're kind of faced with now is we have a drug that has at least benefits as it's defined in the trial with some degree of measurable risk. And each center and each clinician are going to have to weigh whether or not those benefits really do outweigh the risks for them, recognizing that the numbers may suggest they do, but how they kind of weigh the importance of an ischemic stroke based on that kind of composite outcome is going to really be up to the clinician. So a fantastic trial that I think we're all very excited to see come out, but unfortunately, very important questions still remain to really put this debate to bed, in my opinion.
Yeah, and I would just add, sorry, Ashkan,
Go
if I would add that I think we've learned and we are continuing to learn so much from this trial. And to be fair in this argument, I think we also have to recognize that this is the best evidence we have for any form of a reversal agent for any form of anticoagulation. And we can't say the same of PCC for warfarin-related ICH. We can't say the same for protamine for heparin-related ICH. And so I do think that it's worth kind of recognizing historically the context of this trial and how much we are learning about all of this through the trial. And Ash, can I cut you off? So
No. I'm actually glad you raised the historical context. Because for instance, you mentioned PCC for vitamin K related ICH. Of course, you and many of your listeners will know about the INCH study. So that's the best evidence we have for warfarin related ICH, and 4-factor PCC is now standard of care. Well, what was the INCH study? The INCH study's primary outcome was normalization of INR to less than 1.2 within 3 hours of a treatment. And the study was stopped for overwhelming efficacy, and that PCC was much more rapid in normalizing INR, kind of a similar paradigm in terms of the rapidity of normalizing ETP with andexanet versus PCC in this context. And the total sample size was about 50 participants, right? There was no statistically significant differences in mortality, no statistically significant differences in MRS. And there's a table in that publication in Lancet Neuro that many people overlook that looks at thrombotic events. And there was so few patients to look at statistical significance, but it was 7 thrombotic events, including ischemic stroke in PCC versus 1 in the FFP arm. So a 7-fold excess thrombotic events if you look at the numbers at face value, which of course you can't because of the small sample size. But that is what has established 4-factor PCC for standard care in ICH, of course, with some of the earlier trials in non-ICH patients of PCC versus FFP. With idarucizumab, we also don't have a randomized study. With protamine, we don't have any clinical data in ICH. So I think that is important. The second piece is that I do agree that really we have been here before. This isn't the first time where we've had a therapy that goes in opposite directions. And actually, we're doing another trial at McMaster Enrich-AF, where we're now looking at resuming anticoagulation in ICH survivors with atrial fibrillation, where we're faced with all the alternative kind of conflict, where we're trying to reduce thrombotic events at the risk of bleeding events, whereas in ANNEXA-I is the opposite. And really individualized treatment decisions are going to be key. And this is going to be the focus of many of our secondary analyses, trying to define those at greatest risk of thrombotic events, those at greatest risk for hematoma expansion, and then identifying subgroups that have the greatest likelihood of net benefit that could then help clinicians make treatment decisions at the bedside. And one particular variable that's emerging that's quite exciting is what we've termed pre-scan hematoma growth rate. But this is something that's been in the literature for some time now, initially proposed by David Rodriguez Luna and Carlos Molina in Barcelona, and they termed it ultra early growth rate, or ultra early growth, rather, ultra early hematoma growth. And essentially, you basically divide the presenting ICH volume by the number of hours from symptom onset to that scan. And that gives you an average estimate of their growth rate during pre-scan, right? That's not going to be a persistent growth rate moving forward, but the higher their average growth rate was pre-scan, the higher the likelihood that person was to expand. And that was a strong predictor of hematoma expansion and not a predictor of thrombotic risk. So in patients that were in the first quartile, which was about less than 1 cc's per hour, your risk of expansion was 20%. Your number needed treated was about 8. If you were in an intermediate risk category of 1 to 11 cc's per hour, your risk of expansion was about 40%. Your number needed to treat was still about 8. But if you went to that fourth quartile of 11.4 cc's per hour or greater, your risk of expansion went up to 60% and your number needed to treat went down to 4, right? So particularly in those early large bleeds that would translate to higher growth rates, that's where you have the biggest bang for your buck. And then the intermediate and low risk categories, that's when, for instance, factoring arterial thrombotic events are going to be important. So one thing we didn't talk about was that in our treatment interaction for thrombotic events, the majority of the excess risk was in those patients that had a prior MI or stroke. The number needed to harm in that context was 10. So whereas in those that did not have a prior history of arterial thrombotic event, the number needed to harm was 50, right? So the lack of although that was not statistically significant as far as the treatment interaction, it makes good biological sense or plausibility. So that may be another triaging tool. So still a lot to learn, but I do think strongly based on this data, and I know there is controversy, but I think this belongs on the shelf. It would be a shame not to have it on the shelf. The question still is who best to apply it to.
Yeah, and I think that is a really great point, that one of the things we're probably learning is that much like everything in neurology and neurocritical care, a patient who shows up in the ED with an ICH, it's not a one size fits all. And so there may be room for individualization when it comes to anticoagulation reversal. So I think like one other thing that we didn't talk about too much is, we talk about time is brain and time to reversal is so important. And they're two operationally different products as well. I'd be remiss as a pharmacist not to talk about what it actually takes to get a drug to the patient. And I think, and one of the things that's a little unfortunate just about how andexanet is formulated is the low dose takes 5 vials of reconstitution. It's a lot of work to make. So I think one of the other things that'll be very interesting to see is how these sorts of things are operationalized. I think like one of the early protocol amendments, one of the early protocols, and andexanet was compounded for every screened patient, regardless of treatment allocation, to try to optimize that time to treatment, which is somewhat realistic in the context of a controlled trial, given how much time it takes to randomize patients and those sorts of things. But another thing that oftentimes comes up is it's just easier to mix PCC, and whether that may weigh into a patient who is higher risk for a thrombotic event where we give the agent that we can get the fastest that may be slightly lower risk. I think there's a lot more for us to learn about. I think clearly andexanet alpha has a role here. I agree with you. And whether there's individualization that could be optimizing the risk-benefit relationship, I think it'll be very exciting to see.
Excellent points. I agree with you. And I think the cheaper and the more easy the company can make administration of this drug, the greater the uptake. One other point I just want to make, when you said about the trials that have shown benefit for hematoma expansion but never translate clinical outcomes, this really probably the magnitude of hematoma volume growth. That's the key, and this is why we did a 12.5 cc cutoff look as well. There was actually, that all changed now with INTERACT-4. It was just published in New England and presented at ESOC last month. That was a pre-hospital blood pressure control study, and in the ICH subgroup, there was substantial improvement in death and disability, and that was correlated with reduction in hematoma growth. So we do have an RCT now demonstrating the correlation in terms of clinical efficacy from reducing hematoma growth.
All right. Well, this has been an absolutely fabulous discussion, and I could talk about this all afternoon, but maybe we could just wrap up with you, Ashkan. Moving forward, where do we go from here? What you talked about some ideas for future trials. Where are your priorities right now?
So our priorities are right now trying to define subgroups that are most likely to benefit by characterizing those that are at excess risk with thrombotic events, those that are excess risk of hematoma expansion, and then ultimately developing maybe phenotypes of patients that have the greatest net benefit. Separately, looking at interactions with blood pressure, that's another thing that we're interested in looking at, as well as looking at some of the biomarker data, where we're going to be looking at ETP and factor Xa activity in correlation with hemostatic efficacy and the delta and so forth that Andy mentioned earlier. So those are some of the parallel stuff we have ongoing, and we're working kind of closely with our steering committee and publications committee to try to get these out as soon as we can.
Great. And Andy, sort of as a corollary to that, so what are you doing in your actual practice? I know you've had access to andexanet alpha for some time. Are you using it in a one-size-fits-all way, or are you using certain parameters, perhaps some of the ones that Ashkan mentioned, to triage its use in your ED or your ICU?
Yeah, it's a great question. And so, like you said, we've had andexanet alpha available in our preferred formulary agent for DOAC reversal for some time. But recently, in combination with ANNEXA-I and kind of some increased availability of some of the resources for trying to triage those patients, we have adjusted our workflow slightly. And so one of the great things that we recently got available is rapid availability of DOAC targeted or DOAC calibrated factor Xa or anti-10A inhibitor activity, excuse me. And so we've slightly adjusted how we screen these patients for availability of anticoagulation reversal. And that, if you have a patient who checks all the boxes that, were kind of pre-specified in ANNEXA-4 and now ANNEXA-I, where a ICH of an appropriate volume with a clear known last time of DOAC administration and no obvious overwhelming risk factors for thrombosis. We're really just a quote unquote straightforward patient who would benefit from anticoagulation reversal. They would get andexanet alpha really with no questions asked. But in those patients who there is some ambiguity either in what DOAC they take or what anticoagulant they take, which is sometimes unclear, or when their last dose was, or when there's some of those questions about risk stratification, one of the things that we have started doing is sending off those anti-10A activities to try to get a baseline before making a treatment decision, if it makes sense in the context. So oftentimes it's patients who come in with an unclear last known well or an unclear last dose. They're not particularly critically ill, where there's a little bit of time to really try to make an informed decision, where we have the availability of those anti-10A activities. I mean, basically within about 30 minutes, they should result. And based on the threshold, which I don't want to miss, but I'm fairly certain it's 75, but I could double check our protocol. I think 75 is the threshold we chose. They would qualify for anticoagulation reversal. But if we're able to determine that they are effectively not exposed to a factor Xa inhibitor, then we would defer anticoagulation reversal in that context. So I think to our point of trying to risk stratify these patients, I think our practice is moving to really try to select the patients that we feel are the most likely to benefit. And hopefully some of the secondary analyses from this trial, as well as a better understanding of who's most likely to benefit, will help even further refine that practice.
Yeah, that makes a lot of sense. And it's always a fear when we apply trials to real life situations that are much more uncertain. Is sometimes we give remedies for intoxications that aren't present, and that just exposes someone to the risks and none of the benefits. So really interesting framework that you were working under at MGH, and hopefully some of the rest of us will have access to some of those real-time diagnostics to help us triage the use of andexanet alpha. Um, I want to thank both of you for coming on. This was, I think, highly educational for me, and I think our listeners will really enjoy it. I do want to point the listeners to the Neurocritical Care Society X or Twitter Journal Club, which will continue this conversation on Tuesday, July 16th, starting at 9 a.m. Central Time. So if you have your own 2 cents to add to the conversation, please join in on X or Twitter. This has been the Neurocritical Care Society podcast. I'm your host, Nick Morris. We do offer continuing education credits for select episodes, and these episodes are available wherever you get your podcasts. And please like and subscribe. That helps us know that we're doing a good job and that we'll keep the podcast going. Thanks again to Andy and Ashkan, and I'll leave it to you if you have any final words, but we're really thrilled to have you on the podcast.
Absolute pleasure, Nick. Thanks for the opportunity.
Yeah, thank you again for the invitation.
Yeah.
All right, tune in next episode.
Yeah. Bye-bye.
Thanks, everyone.